So we will be starting with question number 101 and we'll discuss up till question number 125 in this session. Question number 101 to 125. So question 101 was classic phenylketonuria is caused by deficiency of, and the correct answer is option number A, phenylalanine hydroxylase. Option number A, phenylalanine hydroxylase. So deficiency of this enzyme causes phenylketonuria or PKU as it is commonly called. So few important things about phenylketonuria. First, that phenylketonuria, phenylalanine is an essential amino acid. And second, deficiency of either phenylalanine hydroxylase or its cofactor tetrahydropterin, deficiency of either of them will cause a condition called phenylketonuria. The severity of the symptoms will depend upon the severity of the enzyme deficiency. The more the deficiency of the enzyme, more severe would be the symptoms. So in this regard, it has been seen that once this enzyme is deficient, the levels of this amino acid increase in the body fluids. And it has been seen that when the levels are more than 20 milligram per deciliter, then in that case phenylalanine may be converted into certain ketone bodies such as phenyl pyruvate and phenyl acetate, and excretion of these metabolites into the urine result in the excretion of the ketone products of phenylalanine results, and that is why this condition is called phenylketonuria. Though these products do not have any role to play in the pathogenesis of the symptoms that occur in this condition, but it only signifies that the disease is severe or the levels of phenylalanine are extremely high. So once the levels increase, there are evidence of CNS damage that occurs, and it has also been seen that increasing levels of phenylalanine will also interfere with the transport of other amino acids in the brain like tryptophan and tyrosine. Important clinical features of this condition include CNS damage. There can be microcephaly. Child can have epilepsy or seizures. There may be cognitive dysfunction. And there may be reduced pigmentation of the skin and hair. And there may also be microcephaly. So these are the important clinical features. And how can you make the diagnosis? Well, diagnosis can be made. In some countries, they have adopted newborn screening for phenylketonuria so that this disorder is picked up in the neonatal period itself, or it can also be diagnosed on the basis of molecular genetic testing. So by identifying the mutation, so by both these methods you can diagnose phenylketonuria, and the condition can be treated by restriction of phenylalanine in the diet. So we come on to the next question, and the next question was, which of these disorders in children is associated with omega shaped epiglottis? And the correct answer is option number A, that is Laryngomalacia. So Laryngomalacia is a very common disorder of childhood, of infancy rather, which results due to large and floppy epiglottis, which largely results due to the poorly developed laryngeal cartilages. And if you do laryngoscopy or a bronchoscopy, you can see that this epiglottis is quite large and is almost like omega shaped. So that is why it is called an omega shaped epiglottis, and it is one of the most common cause of stridor in children. Most common cause of stridor in infants. Usually this condition is self-limiting, and as the child grows, the larynx also grows, the epiglottis also grows, and the stridor wanes away. However, surgery may be indicated if this stridor persists beyond 2 years of age. Next we come on to question number 103. And question number 103 was, clinical manifestations of hereditary fructose intolerance are, and the correct answer is option number D, that is all of the above. Option number D, all of the above. So few important things about hereditary fructose intolerance. So hereditary fructose intolerance results due to the deficiency of aldolase B enzyme. So deficiency of aldolase B will result in hereditary fructose intolerance. Usually the patients with this condition are normally healthy unless and until they intake large amounts of fructose, which is present in fruits and fruit juices. So if they ingest fructose or sucrose, then the symptoms will manifest, and these symptoms can be jaundice, hepatomegaly, vomiting, lethargy, irritability, and seizures. So usually symptoms occur when sucrose or fructose is introduced into the diet. So there are few classical lab findings that you can find in hereditary fructose intolerance, and these are an increased clotting time, there is hypoalbuminemia, there is elevation of liver enzymes, and there is also proximal tubular dysfunction. If there is an acute ingestion of large amounts of fructose or sucrose, it may result in symptomatic hypoglycemia. So this was about question number 103. Next we come on to question number 104. And question number 104 was, partial deficiency in HPRT is called, and the correct answer is option number A, that is Kelley-Seegmiller syndrome. Option number A, Kelley-Seegmiller . So partial deficiency of HPRT is known as Kelley-Seegmiller syndrome, and in this condition you can see hyperuricemia and gout in patients, and this condition is, you should know, X-linked recessive. And another feature that you may come across in a patient with partial HPRT deficiency is urolithiasis, which is basically due to excessive filtration across the tubules. So next we come on to question number 105, and question number 105 is, a 11-year-old boy presents in the outpatient department with complaints of not developing secondary sexual characteristics. On examination, the child is found to have tall stature, no secondary sexual characteristics, testes are found to be small and firm, and gynecomastia is noted. What is the most probable clinical diagnosis? And the correct answer is option number A, that is Klinefelter's syndrome. So option number A, Klinefelter's syndrome, is the correct answer to this question. So you should know that Klinefelter syndrome is one of the most common cause of hypergonadotropic hypogonadism in males. So this is a genetic disorder, and in this it is found that there is an extra copy of the X chromosome, and it has been said that as the number of X chromosomes increase, the severity of the disease also increases, and this condition should be suspected in any boy who is tall stature, who has mental retardation. So Klinefelter syndrome should be suspected in any boy with tall stature who has mental retardation. Often this condition is not diagnosed until adulthood, or diagnosis becomes obvious during the time of puberty, when boys fail to attain secondary sexual characteristics. So it should be, so you should know that this condition also has tall stature. So there is lack of secondary sexual characteristics. And there are psychosocial and learning disability also that are seen in this condition. So this was about Klinefelter's syndrome. Next we come on to question number 106. Question number 106 was, febrile seizure prophylaxis is recommended in all of the following except, and the correct answer is option number C, that is febrile seizures lasting for more than 30 minutes. So you should know if, so question number 106, the correct option is option number C. So you should know that for prophylaxis of febrile seizure, there is intermittent and continuous prophylaxis. So intermittent prophylaxis, you use the drug clobazam in a dose of 0.75 to 1 mg per kg per day, which is given for 3 days when the fever occurs. So parents are supposed to be counseled that whenever there is onset of fever, they should start clobazam and they should give it in this dose for just 3 days for the duration of the fever, because like you know, febrile seizures mostly occur within the first 24 hours of onset of seizure. So this intermittent prophylaxis can be given for children who have either 3 or more febrile seizure in 6 months or who have 6 or more febrile seizure in 1 year. However, continuous prophylaxis may have to be given to those children who have failed intermittent prophylaxis or who have recurrent atypical febrile seizures or if the parents are unable to recognize the onset of fever. So in this condition, continuous prophylaxis may be given, and the 2 drugs that are used for continuous prophylaxis are either sodium valproate and phenobarbital. So these are the 2 drugs which are used for continuous prophylaxis of febrile seizures. So next we come on to question number 107. And question number 107 was, correct statement about tetralogy of Fallot is, and the correct answer is option number B, that is pulmonary stenosis is predominantly subvalvular. So you should know that the pulmonary stenosis that occurs in tetralogy of Fallot is primarily subvalvular in origin. So next we come on to question number 108, and question number 108 was, virus associated with arthritis is, and the correct answer is option number D, that is all of the above. So rubella, cytomegalovirus and parvovirus all are known to cause arthritis. So question number 108, correct answer is option number D, all of the above. And what are the other viruses apart from these that are mentioned in the question that can cause arthritis? And they are chikungunya virus, mumps, which is caused by paramyxovirus, adenoviruses, herpes virus, Epstein-Barr virus, varicella zoster virus, ecovirus, and Coxsackie B. So these are the other viruses which may also cause arthritis apart from those options that are mentioned in this question. So question number 109. Now we come on to question number 109. And question number 109 was, which factor is necessary for the differentiation into testis? So the correct answer to this question is option number A, that is the SRY factor. So the presence of this factor ensures that the gonads turn into testes. So it has been seen that during development, the gonad is in the beginning undifferentiated. So that means it can either become into an ovary or a testis. So it's an undifferentiated bipotential. The fetal gonad is undifferentiated and bipotential, which arises from the thickening of the urogenital ridge, which is close to the area which develops around the kidney and the adrenal cortex. So at around 6 weeks of gestation, this gonad will contain germ cells and the stromal cells, which will either develop into the Leydig cells in testis or the theca or the interstitial cells in the ovary, and the supporting structure, supporting tissues that are involved. So if the SRY factor is present, this bipotential gonad will develop into the Leydig cells in the testis, and if the SRY factor is absent, this will become the gonad will become into an ovary. So it is the presence of this factor, this SRY factor, which determines the differentiation of this bipotential gonad into the testis. So this was about the SRY factor. Next we come on to question number 110. So question number 110 was, the child is able to tie his shoelaces at the age of, and the correct answer is option number C, that is 5 years. So you should know that between 18 to 30 months, the child is very eager to learn dressing and undressing. So at around 1 year, the child will start pulling his socks and mittens. And undressing is learned before dressing. Then at around 2 years of age, they can put on shoes and can undress completely. By around 3 years, they can dress and undress completely if they are helped with buttons. And by 5 years, the child will also learn to tie shoelaces. So this was about dressing and undressing, and tying shoelaces can be done by the time the child is 5 years of age. So next we come on to question number 111. Question number 111 was, a child develops oliguria with altered renal functioning along with thrombocytopenia. There is history of dysentery preceding the episode by 2 weeks. The most likely peripheral smear picture is, and the correct answer is option number B, that is microangiopathic hemolytic anemia with reticulocytosis. So question number 11, the correct option is option number B. And so how you should approach this question? So the clues in this question were, there's history of preceding dysentery. There is oliguria. There are altered renal function. And there is thrombocytopenia. So this is a very characteristic history with lab features. This points to the diagnosis of hemolytic uremic syndrome. So this is the the diagnosis here is hemolytic uremic syndrome, and as the name suggests, there is hemolysis and at the same time there is uremia, so there is renal failure. So these are the important components of hemolytic uremic syndrome. So there are few things that you should know about hemolytic uremic syndrome or HUS. So you should know that basically children with HUS or hemolytic uremic syndrome are classified into two groups. The first group usually results in children who get affected by Shiga toxin producing enteropathogens. So pathogens which produce Shiga-like toxin they cause the first, this is one subgroup of patients which results due to Shiga-like toxin producing enteropathogens. This is the more common subgroup, and usually the children affected are between the age of 2 to 3 years. The second group is that of atypical hemolytic uremic syndrome, which can be seen in children of any age. And it is not necessarily caused by Shiga toxin producing enteropathogens. And usually these children have abnormalities of the alternative complement pathway. So usually, so that is why this history of preceding dysentery is important, because it's basically the causative organism. So the history is there. So now what will you get in lab findings? There would be hemolysis, which will result in anemia. So the PS, if you do a peripheral smear, you can find a lot of helmet cells, Burr cells, and fragmented cells, all that point towards hemolysis. And along with that, there would be thrombocytopenia as well. If you do a urine examination, you can also find low-grade microscopic hematuria. Many a times, and the renal functions will also be deranged. Because it's hemolytic uremic syndrome, like I had mentioned. So because of the renal failure that they have a lot of fluid accumulation, which will also result in hypertension. So when you are managing these patients, if hypertension is a prominent problem, then hypertension needs to be managed. Otherwise, they need symptomatic treatment. So their anemia needs to be taken care of, their thrombocytopenia needs to be taken care of, their hypertension needs to be taken care of, and all other complications that may result due to acute kidney injury or renal failure have to be taken care of. So the treatment is basically symptomatic. So next we come on to question number 112. And question number 112 was, to check the proper placement of an endotracheal tube, one should do all of the following except. And the correct answer is obtain a lateral chest X-ray. So to check, once a child has been intubated, to check whether the tube is in place or not, it is important to check the tube placement, and that can be done by, you can either see for the clinical improvement in the child. If his SpO2 starts improving, if his heart rate starts improving, then that means that the ventilation is going on well and that the tube is in the chest. Similarly, clinically, the chest, the breath sounds can also be heard over the lung fields, whether they are equal or not. Sometimes, because the right bronchus is in line with the trachea, it is often that the endotracheal tube goes more into the right side, ventilates the right side, and does not ventilate the left side. So if there is difference in the breath sounds, then that can also help you to ascertain whether the tube is in place or not. So by listening for the breath sounds over the lung fields will also help you to ascertain the position of the chest tube. And the most objective method to check the position of the endotracheal tube is by monitoring the end tidal CO2. Now, while listening to the chest, to the breath sounds, it is very subjective. Someone might perceive it differently. They may not be able to assess in the presence of conducted sounds. But monitoring the end tidal CO2 would be the objective method. So measuring the end tidal CO2, or sometimes it is also called the EtCO2, is one of the objective methods to know the position of the chest tube. Similarly, a frontal X-ray can also be done to see the position of the tube. So lateral X-ray is not done to check the position of the tube. So hence this is the wrong answer here. So for question number 112, the correct answer is option number D. So now we come on to question number 113. And question number 113 was, which congenital disease is associated with the defect shown in the diagram below? And if you see clearly, this is the abnormality in this image, and this is the single simian crease. So what you see in this image is the single simian crease, which is seen in Down's syndrome. So what would be the correct answer to this question? The correct answer would be option number D, that is endocardial cushion defect. So option number D, endocardial cushion defect, is the correct answer to this question. So what you see in this image is a single simian crease, which is seen in Down's syndrome, which is basically trisomy 21, which results due to an extra copy of the chromosome 21. And few important manifestations in Down syndrome. First, in the cardiovascular system, there may be various cardiovascular malformations, and endocardial cushion defect is one of the most common manifestations. In the GI tract, often in the neonatal period, duodenal atresia or atresias of other part may also result. So duodenal atresia, and apart from that, you can also have in eye, you can have increased risk of so you can have cataract and nystagmus. Apart from that, there can be hearing defects as well. There can be thyroid dysfunction. Often these children have hypothyroidism as well. So there can be thyroid dysfunction, and there can be evidence of atlantoaxial dislocation. So these children need to be monitored regularly and they are also at risk of various malignancies, especially myeloid malignancies. So these are some few associated malformations or defects that can be associated with Down syndrome. So now we come on to question number 114, and question number 114 was, NADA's criteria are used to assess the presence or absence of heart disease in children. Which of the following is not a minor NADA's criteria? And the correct answer is option number D, that is systolic heart murmur of grade more than 3. So option number D, systolic murmur grade 3. So what are the NADA's criteria? NADA's criteria are few major and minor criteria, which in the presence of one major and two minor criteria, it can be concluded or it helps to make the diagnosis of heart disease in the patient. So what are the major criteria? So the major criteria of NADA's are systolic murmur more than grade 3, presence of a diastolic murmur, presence of cyanosis, if cyanosis is present, or if there is evidence of congestive heart failure. And what are the minor criteria? Systolic murmur less than grade 3, so grade 1 and grade 2 can come in this category. Abnormal BP, abnormal ECG, abnormal chest X-ray. And abnormal second heart sound. So if there is one major and two minor criteria, then it can help you to say that the patient may have heart disease, which can be further confirmed by a echocardiography. So question number 115, now we come on to question number 115. And question number 115 was, which of the following cyanotic congenital heart diseases is associated with increased risk of chest infections? And the correct answer is option number C, that is truncus arteriosus. So you should know that cyanotic congenital heart diseases can either have increased pulmonary blood flow or have decreased pulmonary blood flow. Now this will depending upon the presence or absence of pulmonary stenosis. So if there is decreased pulmonary blood flow, that means there is pulmonary stenosis, and in case of increased pulmonary blood flow, there is no pulmonary stenosis. So these conditions which have increased pulmonary blood flow will result in recurrent pneumonias. And these conditions with decreased pulmonary blood flow, which also have pulmonary stenosis, will result in hypercyanotic spells. Or TET spells. So because we know that truncus arteriosus has increased pulmonary blood flow, so the correct answer to this question is option number C. Apart from truncus arteriosus, TGA and TAP-VC will also have increased risk of recurrent pneumonias if they do not have associated pulmonary stenosis. So conditions like Tetralogy of Fallot will present with hypercyanotic spells or TET spells. So next we come on to question number 16. And question number 16 is, one of these is the correct definition of nocturnal enuresis, and the correct answer is option number C, that is involuntary voiding at night after 5 years of age. So question number 116, the correct option is option number C. So now we will just know something about nocturnal enuresis. So nocturnal enuresis is defined as complete or nearly complete evacuation of the bladder at wrong place. So this is the definition of enuresis. So if there is complete evacuation of the bladder at wrong place and at wrong time, at least twice a month after 5 years of age. So then it is defined as enuresis. And now enuresis can be either primary or secondary. Primary results when there has been no interval period when the child has become dry, while secondary is when there is at least an interval of 6 months when the child had shown dryness or he had become continent. So there is another important term with regard to enuresis. So we had studied the definition of enuresis. So if it occurs at night, it is nocturnal, and if it occurs both during the day or night, it can be diurnal. So if it occurs at night, then it is nocturnal enuresis. So monosymptomatic enuresis is when it is not accompanied by any signs and symptoms of UTI. So that is when we say monosymptomatic enuresis. So what is the most common cause of nocturnal enuresis? Well, most commonly it has been believed that maturational delay is the most common cause of this condition. And for therapy, motivational therapy is what is mostly practiced. You should restrict the intake of fluids, especially in the evening time. There are certain alarms also that are now available in the market. Sometimes you can even wake up the child before the time at which he passes urine, and he should be woken up and he should be asked to go and evacuate the bladder. Certain drugs have also been used in the treatment, and amongst the common ones that are used are imipramine and anticholinergics. So this was about nocturnal enuresis. So next we come on to question number 117, and question number 117 is, which of the following abnormalities is not associated with Prune belly syndrome? And the correct answer is option number D, that is meconium ileus. So option number D, meconium ileus, is the correct answer to this question. So Prune belly syndrome is also known as Eagle-Barrett syndrome. And it results in wrinkling of the abdominal skin. So there is lax and wrinkled skin of the abdomen. that results due to deficient abdominal musculature. And apart from this, the skin looks like that of prune, so that is why it is called prune belly syndrome. The skin, the wrinkling of the skin looks like prune. There are other malformations as well in prune belly syndrome, and that is the commonly that are seen as urinary dilatation or the urinary system dilatation along with undescended testis or cryptorchism. Pulmonary hypoplasia may also be seen in some children. And apart from that, there may be some orthopedic, cardiac and gastrointestinal problems as well. System may also be affected. So this was about prune belly syndrome or eagle parrot syndrome. So question number 118. In early childhood, the most important cause of severe dehydrating diarrhea is, and the correct answer is rotavirus. So option number A, rotavirus, is the correct answer to this question. So you should know that in rotavirus, vomiting is an early and an important feature. And the diarrhea in case of rotavirus is profuse, watery and voluminous. And there is no blood or mucus in the blood, in the stools. And because of the morbidity that rotavirus diarrhea causes, now rotavirus vaccine has also been included in the national schedule. So it is now a part of national schedule. And the vaccine that is used is known by the name of Rotavac. And it is now introduced only in few states, but over a period of time, this will be introduced over the entire country. So this introduction is in a phased manner, right now in few states, and will be introduced all over the country in the next few months. So next we come on to question number 119. And question number 119 was, Reye's syndrome is characterized by all of the following except. And the correct answer is option number B, that is presents with deep jaundice. So question number 119, option number B, presents with deep jaundice, is the correct answer. So now, what is Reye's syndrome? Well, Reye's syndrome is characterized by acute, non-inflammatory, encephalopathy along with fatty degeneration of liver. The most common causative or causes of Reye syndrome are drugs, and amongst the drug, aspirin or salicylates are most commonly implicated. Viral infections, infections due to varicella zoster virus, and certain metabolic disorders may be the causative, may be the important causes of Reye's syndrome. So neurogleukopenia and hyperammonemia both these metabolic abnormalities which result in most of the symptoms of Reye's syndrome. Hyperammonemia is seen to cause astrocyte edema, which may result in cerebral edema. And it has been seen that serum bilirubin levels do not increase. So, serum bilirubin levels do not increase beyond 3 milligram per deciliter. So, if you find that the bilirubin levels are high, or if there is conjugated bilirubinemia, then you should consider a diagnosis other than Reye's syndrome. So, Reye's syndrome cannot be seen if there is deep jaundice. So, next we come on to question number 120, and question number 120 is, which of the following extracranial infections is known to cause aqueductal stenosis? And the correct answer is option number B, that is mumps. So, option number B, mumps, is the correct answer. So, I'm sure you know that mumps is characterized by painful enlargement of the salivary glands, most importantly the parotids. It is a contagious viral infection that results due to the virus paramyxovirus. And the most common CNS manifestations of mumps include aseptic meningitis, and meningoencephalitis, which are usually seen 3 to 10 days after the symptoms of mumps appear. So, in these conditions you can often see CSF pleocytosis. Though CSF pleocytosis may be present in almost 65% of patients of mumps, but only 10% may present with clinical symptoms of meningitis or meningoencephalitis. Aqueductal stenosis is a rare complication or association that is seen with mumps, but it is a known occurrence after mumps infection. So, next we come on to question number 121, and question number 121 was, EMG is least useful in the diagnosis of, and the correct answer is option number A, that is cerebral palsy. So, this was about EMG or the electromyogram, and EMG or electromyogram is a technique of recording it is the technique of recording from the muscle. So, normally the resting potential, so the resting muscle is silent. And so, when you insert the needle to record the electromyogram, then because of the insertion or due to the pain, certain potentials would be recorded. And when the muscle will contract, the action potential will also be recorded. So this is the basis of EMG, and it has been seen that in neurological or neuropathies where nerves are responsible for weakness, then in that cases EMG may record denervation or fasciculations. And it is even helpful in the diagnosis of myasthenic syndromes where you can see a decremental response to repeated stimulations. So in case of myasthenic syndromes, you can see decremental response to repeated nerve stimulation. So this is not helpful in the diagnosis of cerebral palsy. Now we come on to question. So now we come on to question number 122, and question number 122 was, a 6-year-old boy is presented to you with progressive muscle weakness and difficulty in walking upstairs. He has difficulty in walking and has a waddling gait. On examination, Gowers sign is present and there is hypertrophy of calf muscles. His CPK is 10,000 international units. Which of the following is the most probable diagnosis? And the correct answer is option number A, that is Duchenne's muscular dystrophy. So in this question had a typical history of Duchenne's muscular atrophy, and the clues here or the suggestions that were going towards Duchenne's were, see, it was a 6-year-old boy who had difficulty in climbing stairs, so that means there was proximal muscle weakness. So difficulty in climbing stairs. And there was progressive muscle weakness. He had difficulty in walking and had a waddling gait. Then on examination, Gowers sign was present. And on laboratory examination, his CPK was found to be in 10,000 international units. So all these are favoring Duchenne's muscular dystrophy. And apart from that, they've also mentioned about hypertrophy of calf muscles. So this is also important. So this is a typical history that you can get for Duchenne's muscular atrophy. In fact, many a times, this is the presenting complaint. Sometimes they don't notice the gait abnormality that occurs in children and they come with the complaint of hypertrophy of calf muscles. So you should know that Duchenne's muscular dystrophy is an X-linked recessive disorder. So only boys would be affected. And the females in the family would be the carriers for this. So it's an X-linked recessive disorder. Symptoms usually begin at the age of 4 years in boys, and symptoms may begin with a difficulty in walking or a waddling gait. And Gowers sign is a characteristic sign that is seen in examination which indicates that there is a proximal muscle weakness. Usually loss of ambulation occurs by around 14 to 15 years of age. And death ultimately occurs in the 3rd decade, mostly from cardiopulmonary compromise. So next we come on to question number 123, and question number 123 was, hind milk is rich in, and the correct answer is option number B, that is fat. So you should know that the composition of the breast milk varies even during the one breastfeeding session. So the fore milk, or the milk that comes in the beginning of the lactation or the beginning of a breastfeeding session, is rich in water, the fore milk, and it satisfies the baby's hunger, baby's thirst. While the hind milk, which comes later in the breastfeeding session, is rich in fats, which will satisfy baby's hunger. So you should always tell the mother that she should not be very quick in just feeding the baby and just removing the baby from the breast. He should get an ample time to feed so that he can get both the fore milk and the hind milk. So next we come on to question number 124, and question number 124 is the commonest cause of intestinal obstruction and abdominal pain in children between 3 months to 3 years of age is, and the correct answer is intussusception. Option number A. So intussusception is one of the most common cause of abdominal pain that occurs in children between 3 months to 3 years of age, and it basically results of telescoping of proximal segment of the intestine, which becomes the intussusceptum, into a distal segment, which becomes the intussuscipion. So this may be either ileocolic, colocolic, or ileo-ileal. Usually it can be seen in children at the time of weaning or following introduction of a new food, or after vaccination, or after any viral infection. Red currant jelly stools, abdominal pain. Obviously a young child, 3 months old or 4 months old, will not be able to tell about the abdominal pain, but the child may crying incessantly and he may sometimes pull his legs over his abdomen. So that is how the symptom of abdominal pain can be discerned in young children. So red currant jelly stools, abdominal pain, and right lower quadrant mass, a sausage shaped mass. This is the classical triad, clinical triad that can be seen in a patient of intussusception. This is the classical triad, and ultrasound would be a good non-invasive way of diagnosing, and the characteristic or the diagnostic sign that can be seen on an ultrasound is the donut sign, which if present can help you to make a diagnosis of intussusception. So question number 124. Now we come on to question number 124. Question number 125, sorry. Question number 125 was a 3-year-old child presents to your clinic. The mother states that they have run out of creams prescribed for her son's eczema and the child is itchy. She is concerned because there are some round blisters and open sores with a crusting in the antecubital fossa, popliteal fossa, and the face where the itching is worst. Which of the following is the most likely pathogen involved in this pattern of infection? And the correct answer is option number A, that is herpes simplex virus. So you should know that patients who have atopic dermatitis have certain abnormalities of the innate and the acquired immune system. which will result in heightened susceptibility to bacterial, fungal and viral infections. So the common organisms that may be implicated in patients with atopic dermatitis are Staph aureus. So because of the toxin that they produce, Staph aureus, Malacia furfur, Molluscum contagiosum, herpes simplex virus resulting in herpes, eczema herpeticum. These are the common organisms that may cause superadded bacterial infections in patients with atopic dermatitis. So next we come on, so this was about question number 125.